Okay, good morning. I think we're ready to get started. So this is Mark Arnold. I'm Senior Vice President of Marketing with ZAP Surgical. Welcome and thanks to everyone for joining us today for what is our 7th webinar as part of a series of 11 talks over 11 weeks. And being the 7th talk, we have 4 more talks in the queue for you. I encourage everyone to go to the URL in the upper right-hand corner, http://SRS-webinars.com to take a look at the other talks that we have in store for you. And also on this website, you can find recordings to select previous webinars as well. We're also very excited to announce an encore presentation of the introduction to ZapX Radiosurgery. This was originally hosted on April 30th, and due to high demand, we will have the encore presentation again with Dr. Adler on Wednesday, June 17th. I encourage everyone to register for that. It will not be available for offline viewing, so attending the live event is key. That event will be at 7 p.m. Central European time, 1 p.m. Eastern time here in North America, or 10 a.m. Pacific time. One last order of business before we get started. If you'd like to submit any text-written questions, you can do that using the Q&A button at the bottom of your Zoom console. And time permitting, today's presenter, James Hugh, will address those at the end of this talk. So without further delay, I'd like to introduce today's moderator, Dr. John Adler. Dr. Adler is the CEO and co-founder of ZAP Surgical. He's also the inventor of the CyberKnife robotic radiosurgery system and professor emeritus of neurosurgery and radiation oncology at Stanford University. Dr. Adler, over to you.
Thank you, Mark, and I'd like to thank all of you for joining us this morning, and as well a shout out, of course, to ZAP Surgical for putting this on, and also kind of somewhat ironically COVID-19 for making this series of lectures possible, which I think have been very both enjoyable and effective over the last couple of months. I'm delighted to welcome today's speaker, Jim Hugh. I understand he does go by Jim. Jim serves as the Senior Vice President of the American Medical Accounting and Consulting Group, which really involves all things regarding medical reimbursement, as well as a number of other critical medical administrative concerns. Not only that, he's a noted scholar, which strikes me as impressive. Being a scholar myself, he's published more than 30 articles. Go Jim. So today, Jim is going to be talking about, the title of his talk is Understanding Radiosurgical Reimbursement Trends, Past, Present, and Future. And I'm just going to preface his talk with the humility with which I approach this topic myself. Like a lot of medical scientists, like a lot of clinicians, academics, we like to think that science drives medicine. But I've learned the hard way in life that actually, in many respects, reimbursement drives medicine. And that is why it is so important to understand what Jim's about to talk about this morning. So without further ado, welcome, Jim. Looking forward to hear what you have to say.
Thank you so much, John. I appreciate the introduction, and thank you, Mark, as well. And I appreciate ZAP for asking me to give a talk on radiosurgery today. And we're just going to cover, we're not going to go into billing to bore you, but we're going to cover the basics of what procedure codes we utilized and what happened with radiosurgery in the past, what's happening now, and what we might expect maybe in the future. Next slide, please, Mark. So in the beginning, I'm kind of new to the field. Back in the 1980s, when we were working on SRS, the only thing out there really was Gamma Knife. And we had some bolted down Linux systems. And it was mostly a radiosurgery, had the word surgery in it. And a lot of the payers were always confused because they just thought it was an actual surgical procedure, invasive with a knife. And it took probably into the 2007 era till most of the payers understood that it really wasn't an inpatient procedure and that it was an outpatient. But back then, it was mostly paid per diem rate or a diagnostic-related group or an inpatient DRG. One of the issues I asked CMS, or the Healthcare Financing Administration way back then, why do you call it an inpatient procedure? Well, they had called up someone in the Northeast and they had said they were all done inpatient. So they thought the entire country was doing SRS inpatient. And the standard code back then was 61793. The hospitals used it, the physicians used it, and it covered anything, any part of the body with SRS. But mainly, it was the gamma knife that was there. So it was paid at cost in the outpatient setting. So if you put a code 61793, whatever your costs were, CMS paid it. No problem at all. Next slide, please. And then the prospective payment system came along. CMS figured out that they were paying a lot of money out for outpatient systems, especially for SRS. And they said, well, we've been paying inpatient services prospectively for a long time, since Lyndon Johnson. And we're going to make it prospective. That means if there's no procedure code, you don't get paid. So it was very new for hospitals, and this started August of the year 2000. So there were new codes developed, so hospitals could actually put many different codes for planning, for dosimetry, physics services, everything. And then that kind of went into started the progression of codes changing. Go ahead and next slide, please. So, let me see. So these were the codes that were invented right off the bat in 2000, August of 2000. G0173 was for LINAC base, complete course of therapy in one session. So that would be our normal, what we call SRS today, which only happens in one session. And that's the complete session. And then if there was a cranial or spine that required more than one session, then they had the code G0251, which had a maximum of 5 sessions. So this 5-session thing started way back in the year 2000. And then the planning code was G0338. And the dates I have up here are when they were deleted. So the planning code for LINACs was deleted in 2006, and the G0173 SRS LINAC and G0251, which is now SBRT, it was actually SRT back in the 80s. That was deleted in 15. Next slide, please. Then the multi-source COBOL, that code for planning was G0242. It was deleted along with the LINAC planning code in 2006. And then the actual treatment code, one session, G0243, got deleted in 2007. Next slide, please. Now, 2004, all brand new codes, and some of them were developed for image-guided robotic systems. Next slide. And these codes were G0339, which is single session. Most everything is image-guided robotic after 2006. Everything had some capability of image-guided robotic. And so this code was deleted in 2014 for hospitals. Hospitals could no longer bill the G codes for SRS or SBRT. They could only use them with non-federal payers, and freestanding centers could use the G codes as well. And that's been in the Part B physician fee schedule since 2006. Next slide, please. So this was for, very strange too, so if you were doing a cranial or spine lesion and it required 5 treatments, you would bill the G0339, the previous code, and then G0340, fractions 2 through 5. Next slide. Then in 2007, there were new codes, brand new codes all over again, developed to replace SRT, which was stereotactic radiotherapy. Now it's called SBRT. So SRS and SBRT had brand new codes. And then I said previously in 2014, the image guided codes, the G codes, were deleted for hospital use, but freestanding centers could still use them. Next slide, please. So 2001, we had various G codes. The new 2007 codes were brought forward. And this was the first time, as I previously mentioned, that CMS understood SRS, SBRT were outpatient, not inpatient codes. We had to get a lot of changes made in hospital. The APCs changed to reflect that these codes are for outpatient as well as inpatient. Next slide. So one of the new codes created in 2007 was 77371, and that was for multi-source cobalt units. Doesn't matter what kind it was. If it had cobalt, you would bill this code. And this was 3D or inverse planning was utilized for 77371. And this code was actually protected for quite a while. It paid way more than LINAC-based SRS codes. So if you go back in time and you look at the payment rates were like $7,600 for 77371. And for 77372, it was like $3,000. And this was kind of a political game back then. The Senator Specter from Pennsylvania protected the payment rate on this code. But when Arlen Specter lost his seat in the Senate, Congress passed a law that there was a law formed, but in that law, there was a statement that all SRS will be paid the same. Next, please. So here's the payment rate last year and this year. And this code, 77371, and the code I'm going to look at in a minute, 77372, they're called J1 comprehensive APCs. And a J1 code is extremely important because everything on that claim form is paid the flat rate that you see up there of this year, not geographically adjusted, of $7,900. In addition to that $7,900 flat rate, not geographically adjusted, you could bill these 10 codes in addition and be paid separately. But what the problem is with, and we'll go to the next slide so I can explain it so you can look at that code, 77372. This is for LINACs, not cobalt or multi-source cobalt machines. So any LINAC machine doing a single session cranial or spine right below in the cranial area, you would bill that as 77372 one time, and that's all for that course of treatment. The payment rate for that is identical to 77371, and these 10 codes you can bill as well. Now, the difference between a lot of the 77371, those are frame-based, so everything is performed on one day. With LINAC-based systems, you can perform separate procedures on different days, the MR codes, et cetera. And what that allows you to do is, this is a J1 comprehensive APC as well. So if the 77372 is performed the day, everything with a date of service as of today would be billed on one claim. Everything performed prior to today, like Tuesday, Monday, and the previous week, would be on a separate claim form billed. And then everything starting tomorrow, Thursday, forward, would be on a separate claim form as well. This is a mistake a lot of hospitals do. Next slide, please. Then we have the SBRT code, 77373. So if you have a cranial upper spine and you're treating 2, 3, 4, 5 fractions, you would be using code 77373. And we did an exhaustive study for CMS, charged them a lot of money, and we determined that the head was part of the body. So if you're doing multi-session SBRT, you can no longer use the single session code 77372. You must use the SBRT code to, for the first, second, third, fourth, and fifth fractions. Next slide, please. So this is just a statement from the government that explains what SBRT is. And it's a course of 1 to 5 total treatments. If you have 6 treatments, then it's no longer SBRT and it's IMRT. You cannot bill more than 5 total treatments. Next slide. This is a very interesting issue that's going on right now, and we've enlisted the help of ASTRO, ACR, and they're contacting the various payers. This is First Coast, the Florida Medicare Administrative Contractor policy as of April 19th, just a month ago. And they're saying that SRS is delivered in 1 to 5 fractions. This is absolutely incorrect. It's only 1 fraction. And then if you look at the bottom where it says SBRT is used to treat extracranial sites, this is absolutely incorrect as well. It's for cranial and extracranial sites. And we're all trying to get Noridian, First Coast, and several other of the Medicare administrative contractors to change their definition. Next, please. So this explains from CMS what 77371 is. I don't really, or 77372, and it discusses what it's for. It's for cranial. And it actually says down below, it's for 1 to 5 fractions, but no more than 5. The government and payers use SRS, SBRT interchangeably. They don't mean that you have to use 77371 5 times or the LINAC base 77372 5 times. They're just saying that it can be done up to 5 times, but you really would have to use another code. Next slide, please. Now, this is the explanation from CMS about the 77373, and they're talking about fractionated cranial, SRS, or extracranial. So this is where they kind of get in to the actual meat of what codes you should be using for what procedures you're performing. Single session, 77371 or 77372. In ZAP's case, you would be using 77372, or SBRT ZAP, you would be using 77373. Next slide. SRT is not radiosurgery. I've sent many emails over to our European brethren saying, quit calling it SRT, because in the United States for the last 5 years, SRT by the government and the payers is called superficial radiation therapy for skin. And if you have more than one physics plan, if you're treating a brain and a spine at one time, you would have 2 plans for that. So just make sure all of your orders and your documentation state SRS or state SBRT. And if you're calling something another name like Sabre, please don't use that in your medical documentation, as the payers who write the check to you do not know what Sabre is. They understand what SRS is. They understand now, after many years, what SBRT is. So if you're inclined to use the word Sabre, put it in parentheses, please. Next slide. Physician presence with LINAC or any type of equipment. CMS put in their federal registers back in 2011 and 2013 that they are extremely concerned about physician presence. So the physician is at the console while the patient is being set up, and then once the patient starts treatment, then they can leave. But there's been many cases with the Department of Justice and the OIG about physician presence from well-known universities who've had to refund the money back. Next slide, please. Documentation, this just explains if you're doing SBRT, for example, you're just going to produce a procedure report. These codes for the radiation oncologist professionally, they're the management code. You don't have to have an on-treatment visit anymore because you're not billing the on-treatment visit code like with normal external beam with photons, protons, electrons, neutrons, etc. With SRS and SBRT, it's a procedure report, and with SBRT, there has to be a note every day of treatment. Next slide, please. 77432 matches exactly the technical code billed by the freestanding center of the hospital, 77371 or 77372. This is a professional only code. It went up a little. Procedure report is required. The surgeons cannot bill this code. They have to bill their own codes. Next slide, please. 77435 is strictly for SBRT, and it's billed only once. So if you're treating cranial spine lesions 2 times, you would bill this 1 time. If you treated 5 times, you would bill this 1 time. And it got a little increase as well. These codes include image guidance. They don't include verification simulations, but they include image guidance. Next slide, please. So here's a description from the AMA back when they invented these, I think in 2007. So if you take a look at it, image guidance and the respiratory correlation and all of this information is approved in real time. That means the physician is at the console. So all these things are done in real time. Next slide. Here's, I just wanted to throw up the neurosurgery codes for actually the cranial lesions and then for spinal lesions. And this is what they were paid in 18, 19, and 2020. And it looks like the government's been bringing these codes down a little bit over the years for the neurosurgeon. There's a final payment rate for the neurosurgeon's codes. Next slide, please. So these are, if you're doing it in inpatient SRS service, this is the procedural coding system. This is the system that I thought Medicare was going to use for the alternative payment model, where, for example, if we were doing radiation therapy to central or peripheral nervous systems, stereotactic radiosurgery to the brain, photon radiosurgery, isotope ZZ, that they would pay a flat rate utilizing the already existing procedural coding system, but they're not. Next slide, please. So the future, what is the future hold for us? Everyone knows what the RO modeling is and the alternative payment model system. I really don't think, I can say that probably with quite authority, that I don't think anything will be happening this year and probably will not go into effect until the earliest latter on in the year 2021. Probably it will, the final rule for the alternative payment model, the proposed rule came out in July of last year. They must publish the final rule prior to 2022 or everything disappears. The Supreme Court has gotten a hold of the Affordable Care Act. If they axe that, then the Centers for Medicare and Centers for CMMI, Centers for Medicare and Medicaid Innovation, which created the alternative payment model, could go away, but I doubt it. So let's look at the payment rate. So we have a CNS tumor, the flat rate paid over 2 payments, and then the 20% paid by the secondary insurance would be a total of $2,500 for the doctor, and the technical payment would be $14,621. This is not geographically adjusted. So you can see where if, in the previous slides, we were getting $7,600 plus 10 other codes, which would amount to around $9,000 currently. Under the alternative payment model, we're going to get a drastic increase in payment of about $14,600. Next slide, please. So, frameless case study. So these are the frameless systems. Things are billed on different day. Please, these are examples only and don't use the dates shown. I actually have to say that because some people just took a lot of this that I put up on the slides and billed exactly what was there on those days. Next slide, please. So the 77011 I show it as a no charge. This is a technical only for the freestanding or the hospital. The AMA said you can no longer bill these kind of codes, and to bill the 77011, the center would have to be accredited and the technical staff would have to be certified. These are called advanced imaging. The 77014, the CT guidance regular code, is not in the advanced image guidance where you need accreditation or certification, and may be billed in the Federal Register, but the AMA says you can't. So there's really conflicting stories from the AMA and from the federal government, the federal CMS government law. The 77290, this would be the initial setup, positioning, and simulation of the patient. And then you would have immobilization devices, the mask, etc. Maybe a custom bite block, which would be billed in addition. You would have the physician treatment planning code by the radiation oncologist, the special treatment procedure code. Next slide, please. The other way. Yeah, okay, good. And then our planning code, 77295, which was pretty much invented for stereotactic radiosurgery, SRS and SBRT. And Carl Bogardus, Dr. Bogardus had a lot to do with this when he was president of the ACR, bringing this code forward in 1992 and 4. Day 3, verification, there would be dosimetry calculations. They could be, both of these could be billed on day 2 or day 3. It doesn't really matter. It's when they're performed, documented, and approved. Next slide. Then we have the simple sim of the verification on the first day of treatment. This is not a guidance code, it's a verification code. Then we would have beam modification devices that were billed. Those could be billed on day 2 or day 3. Then if you were a hospital billing non-federal payers or a freestanding center, you might bill the G code for the first treatment. Most people, hospitals billing Medicare, would bill 77373. The physician for 1 treatment or 2 or up to 5 would bill the professional code 77435. Next slide, please. And then you would bill the G code, if appropriate, for the 2nd, 3rd, 4th, and 5th treatments. And then lastly would be a continuing physics that would have to be checked. The physicist would need to check this while the patient is under treatment. Next slide. So SRS frame versus frameless. We're talking about frameless systems. So frame-based system, many codes are bundled, everything's in one day, little less payment. Frameless systems, less codes bundled, more payment. Next slide, please. And that's it for our presentation today. I'll go ahead and take questions.
Thank you, Jim. So a lot to digest. I'd like to think my advanced degree in life would help me with this, but sometimes I'm overwhelmed. First question comes, I'll read it to you. It's in 2 parts, but let's start with the first one. Can you please speak briefly on the pediatric radiosurgery and SBRT treatment delivery valuations and any difference in billing between pediatrics and adult patients?
Actually, there is no difference in pediatric and with adults. They're the same codes that you bill. There really is no difference. The added, sometimes it supports the billing of the special procedure code when a pediatric patient is being treated, as usually they're under anesthesia and it's more difficult, so you get the benefit of the special treatment procedure code. Now, Evacor, a radiation oncology business management company, and Astro, as of last year, said they didn't think it's appropriate anymore to bill the special treatment procedure code 77470 for SRS or SBRT. But surely it would be utilized for pediatric cases. In our company, we're still billing for the special treatment procedure for SRS and SBRT, as if the physician has to go to the console every single day, that's pretty special to me. Next question.
So I don't even know what the ROAPM is, radiation. Anyway, with the ROAPM, we have mainly oncology disease sites in the initial rollout. When do you expect to see benign and functional neurosurgical indications included in these bundled payments?
We're waiting. That's a very good question. We're waiting on that for the final rule to come out. What basically the Centers for Medicare and Medicaid Innovation did was they did a pretty good job, but they just threw it out there, and whatever stuck to the wall, that's what we came up with. And there were many. We sent in 4 comment letters. Everybody did. Astro, AMA, everybody. There was a lot of problems with the alternative payment model. And hopefully they read all those. And when they do finally come out with the final rule, that will be addressed as well.
Your numbers, your presentation shows how poorly freestanding centers get paid. I've heard rumors that maybe under the alternative payment model, this is going to change, but that is my question. When are freestanding centers going to finally get paid at a reasonable rate?
Well, that's another very good question. If you happen to be the lucky people who live in New York or California or Nevada, freestanding centers make a lot of money because they bill the G-codes. If you take a look, the G0339 and the G0340 codes, they're in the Medicare physician fee schedule, but they're a C code, as in cat, C as in cat, and they're paid by each state separately. So if you Google and you go Medicare fee schedule, California C codes, it'll bring up the fee schedule, and you'll look and see that they're paying, like California, depending on what location you're in. The G0339 pays about $3,600, and then the G0340 for fractions 2, 3, 4, and 5 paid $2,600. So you're actually making more money than the hospitals are in a freestanding center. If you happen to live in Florida, Florida doesn't pay the G codes very well. They don't pay them very well in North Dakota. So you would be billing the 77372 and 77373. So currently, look up the G codes, see if you can bill them, and bill the G codes. If you're in a state where they don't pay them, then you've got to bill the 77,000 series. And in the future, like I showed you, that $14,600 payment rate, that will be for hospitals or freestanding centers. There is no differential.
A very big deal.
Next question.
Yeah. So, we are seeing a state Medicaid not pay the neurosurgeon code 61796 through 61798 in the freestanding center. Should we try to contact Medicaid and request that they change their policy to pay neurosurgery codes in freestanding setting? Again, a freestanding question.
Well, that's you guys are coming up with some really good questions. The depending on what state you're in. Pardon?
Go ahead. I'm sorry.
Medicaid is a different animal. I don't know why they call it the Centers for Medicare and Medicaid Services, because Medicaid pretty much goes off and they do what they want to do. But there are a few things that CMS, Mother CMS, can force them to do. You could contact the local CMS regional, like if you're in California in that area out west, the CMS regional office is in San Francisco. In the southeast, the CMS regional office is in Atlanta. And you can tell them, and I would write a letter to CMS, to Medicaid, CC'd to the regional CMS office, that these codes are appropriate and that these are outpatient services as well as inpatient services. So they probably got the neurosurgery codes in your area's Medicaid, in your state Medicaid, listed as inpatient only. So if you're a freestanding center and you're doing SRS and the surgeon comes and bills their codes under place of service 11 office, they won't be paid. So this will take a coordinated effort, contacting the Medicaid, the higher ups as you can get, with CCing to CMS regional. Next question.
Strategy. I don't know where the question came from, but good idea. So next question, and a logical question, is can you bill more when treating metastatic patients in a single session?
The neurosurgeons can professionally. Technically, they're the only thing that you would bill in addition. The payers, CMS as well, Medicare, considers the cranial area as an area. So if you have one lesion or 50 lesions, they really don't care. It's an area. Like the left lung is an area, right lung is an area, both kidneys are separate areas, but the brain is one area. So the only additional amounts of money that would be paid would probably be for dosimetry calculations, the extra ones that you have. And depending on the state you're in, remember all the payers, even if they're the same, Medicare, United Healthcare, each state is different. Each state has their own policy. So if you're lucky enough to live in a state where you had, let's say, 5 lesions and 25 dosimetry calculations, they would, you could appeal it and they would pay all 25 because the payers are used to seeing multiple dosimetry calcs over 10 for SRS for decades. They kind of understand that principle. Every other body part they don't, but they're pretty much focused that when they see a cranial area, that there's going to be more than 10 dosimetry calculations. But if you live in a state where you're, for example, in Georgia, I bill Medicaid 10 dose calcs, they're paying 1. In some areas of the country, Anthem will only pay up to 6 dose calcs. So it depends on the state you're in. Next question, please.
Did you say, in part of your answer, did you say that the professional neurosurgeons can bill more for treating multi-mets?
Yes, in my slide presentation, we had a code for simple lesions for cranial, and they build the first code, and then they can bill up to 4 of the what's called an add-on code. So if they had 5 lesions, they would be paid for 5 lesions. If they had 3, they would be paid for 3. But that's only the neurosurgeon, not the radiation oncologist, and not any of the technical charges being billed.
Gotcha.
Next question.
If that questioner still feels we haven't answered the question, let me know. And lastly, last question I think is, are there separate codes for physicians other than RADOCS for participation in SBRT and radiosurgical treatment planning process? Question is, now we're talking about the rest of the body, can pulmonologists and urologists assisting with target delineation bill for their effort? So we're talking about non-neurosurgeons' involvement in radiosurgery.
That's a good question. Yes, there is. The thoracic or pulmonologist, they have a code called, I think it's 32721. It's a 32,000 code. That's for lungs. And the rest of the body, there are no codes. So for urologists, for surgeons doing pancreatic cases, etc., they have to use an unlisted code, appeal it, and then submit an op report. The old code, strangely enough, 61793, that was deleted several years ago, anyone could bill that code, a urologist, a neurosurgeon, a thoracic surgeon, anybody. And that's what the government didn't like in the AMA. They said, you got to get your own codes, so we're going to invent brand new codes for the neurosurgeons. So the only other physician that has a separate code is for lungs, the 32721, I believe it is.
So in many places, head and neck surgeons are involved in radiosurgery. for like vestibular schwannoma and other kind of benign skull-based lesions, and maybe even potentially going forward in head and neck. Can they bill the neurosurgical codes since this does involve the head?
Yes, if it was right in the cranial area and the brain stem and spine right below, that could be billed by any surgeon in that area. But for lower head and necks below that, I don't think they would. Anything in the cranial area down, I think probably right at the upper spine, any surgeon could bill any of those codes for cranial area, yes.
Well, presumably not urologists, unless the patient had their head up their ass or something, but okay.
No, that wouldn't work.
Okay, well, I think this was short and to the point, although amazingly complex material, and I really appreciate you giving us your time here this morning, Jim, and I appreciate all the attendees for participating this morning. With that, I wish you a pleasant day and hope to see you at our future next meeting, next conference next week. Mark, what is the topic next week?
Next week, it's Thursday. We have Mohan presenting ZapX treatment planning, redefining simplicity and efficiency.
I'm sure everyone who watches is going to be dazzled by what Mohan has done in the world of inverse treatment planning. So, well, thank you, Jim. Thank you, all the participants, and have a great day. Bye-bye now.
Thank you, Dr. Adler. Thank you, Mark. Everybody have a good day. Be safe.
Bye-bye.
Bye-bye.